invite Dr. Abhay Vasavada for his presentation, Physiological IOP-based phaco surgery, new standard care. There is no need to give any introduction, Dr. Abhay Vasavada. He is a pioneer and he is a stalwart of doing the phaco surgery.
Okay. Right. Good afternoon. Thank you for the opportunity, and thank you, Boris, being here. And Boris, thank you for being here, and it's a great encouragement for me. There's no financial relevance to this presentation. Although I do receive research grant, and probably there is some, because I do receive research grant from Alcon. Why do we talk about this intraocular pressure? When I started for many years, I never understood when I was hanging the bottle at 90 centimeters or 100 and through the sky. I never understood that there is a thing called intraocular pressure during surgery. It's only the glaucoma patient had an IOP, so we never thought of it. But it has an impact on the eye, and many stalwarts have shown it. We published in 2010, 14 years ago, that the higher aspiration flow rate, which is married to higher bottle height, caused more corneal edema and anterior segment inflammation on post-operative day 1. It didn't matter down the line after 3 to 4 weeks, but it did on the first day. So that was an opening for us that we need to do lower. And why it is that? And that is because of the intraocular pressure, absolute going high, but also fluctuation. As you would see here, with the higher flow rate and higher bottle height, there's a lot of fluctuation compared to a lower bottle height. At that time, we did study with the Legacy, I think, or Infinity, but the point is that lower bottle height at that time produced a very low IOP rise during the surgery and low fluctuation. And that opened the eye of the industry. And I think here you are, not only Alcon, but also Bausch & Lomb and some other companies are now are playing with this intraocular pressure control with various ways during the surgery. And this is the typical example of a gravity-based emulsification, which most of us do even today. Nothing wrong clinically in the sense, but if you really are very critical, this is what you will find, fluctuations and things. So that's something we realize when we compared that later on after a few years with the newer concept of active fluidics, that it was much better looking. And what Dr. Samresh Srivastava, my colleague, showed it is beautiful, and this is an award-winning video. What he did in eye bank eyes, that he did irrigation on and irrigation off with intact posterior capsule. And you see the fluctuation of that posterior capsule front and backwards, no rupture. And then we did this some time ago. So we raised the bottle height, and more the bottle height and more the flow rate associated with it, would expect that would have more fluctuation. So he injected Trypan blue in the anterior chamber and then continued the experiment. And in spite of the intact barrier, the posterior capsule and zonules and everything, with so much of fluctuation, we detected triamcinolone into the posterior compartment in spite of the intact capsule. So this is what a high bottle height, high flow rate in some eyes can produce. This is a cadaver eye, so it doesn't happen in every human eye, but it can happen in a compromised, some eyes which are filtered, low IOP, vitrectomy eyes, or whatever. We don't know. So that something was important, and these kind of technology, and there are a few others also who really give a good control but this is one of such a fluidic system which really allows us to work at a lower IOP. How low? It depends on your comfort. If you always enjoyed 110 centimeter and 45 centimeter flow rate, you will not be very comfortable at 20 millimeter of IOP, but you will be able to bring that IOP significantly down. I am a timid person, and I use 20 IOP, which translate to 30 centimeter bottle height, or 30 IOP at the most, generally as a rule. And I am comfortable with it. And I do this because of the IOP experiments that we did several years ago. And I'm really convinced that if we can avoid rise of IOP, even for a few seconds, and also fluctuation, it has to do some good. We may not be able to document that impact every time with the existing investigative technology that we have. So that's a different thing, but even while you remove the fragment with 20 cc flow rate and 20 IOP with appropriate vacuum, we are able to continue. It would take a minute or two more because of the low flow rate, but it's not a big deal. More important and priority is the impact of the eye. So that's what it is. And managing floppy iris essentially actually is to maintain the pressure gradient in front of the iris and posterior to the iris. And if you can balance that in such a way that the anterior IOP is always higher a little bit than the posterior compartment behind the iris, you will never get iris prolapsing to the incision, as you could see here. And in the 40 IOP, then if you reduce it to 30 even, you will find that you will be able to continue this procedure now with less chance of IOP. Once you deposit that iris which has been caught into the side port, it will never come back again because the IOP is less and the posterior pressure behind the iris will be less, and so on. So I think managing these compromised eyes and the iris tissue, what you need to understand is lower is better than the eye. And if you are finding difficulty, the rule, Murphy's law here, is that reduce the parameters, reduce the fluidic parameters, and generally it will work and does the trick. This is one more example of a dense cataract with a small pupil, and you are able to do that with 30 IOP, which is about 44 centimeter bottle height and 20 centimeter with a reasonable comfort and the speed. It will not be as fast as the higher flow rate, but it's sufficient to continue with the balancing out. So as I said, we're in trouble, lower your parameters. So this is the case, all set for a difficulty in all aspects of it. And my default IOP is always 20 for a long time. I do go to 30 IOP and sometimes to 40, but generally never above 50 IOP. And we get worried when the IOP of the glaucoma patient goes in 30s, and we don't worry here, primarily because it's for a short time and it's not continuous because of the procedure. But still, it can matter in a compromised hemodynamics at the optic nerve, or even in the short ciliary vessels in the choroid. So I think lower IOP makes sense. We do not have enough evidence in every aspect of the impact, but it does make a sense, and therefore I would urge you to consider keeping the IOP as low as you are able to comfortably do it, and assure you, you will be able to achieve that IOP gradually lower and lower as you understand. And we did this study of the infinity and conventional phaco and newer technology, and we found that the newer technology allowed us to use lower IOP with a much more beneficial impact on the post-operative outcome. So finally, I think we all understood, all the industry, we must thank everybody involved in this development of the machines and technology. Most of the companies are bringing wonderful technologies today with the techniques and experience. We can optimize outcomes using as low IOP as you are comfortable with and achieving a good outcome even in a challenging situation. So thank you so very much.
Okay, thank you very much, Dr. Abhaykumar. So we do